All right, everybody, welcome to Optometric Education Consultants National Webinar Series, special Monday night edition. And tonight's topic is pharmaceutical update in dry eye, blepharitis, keratitis, and ocular disease with our speaker, Dr. Greg Caldwell, who along with myself is a co-owner of Optometric Education Consultants. He's a fellow of the American Academy of Optometry. He's a diplomate of the American Board of Optometry, past president of the POA. He has been on the AOA board, and here he is with us tonight to give us some great online education. So, Greg, please take it away.
Thanks, Joe, and thanks everyone for attending again. Pharmaceutical update. We're going to jump in here with disclosures. I've lectured from Alcon to Dompe, have been an advisory board from Dompe all the way down to the Optometric Advisory Visionary Team. And I do sit as a non-salaried I do have a non-salaried financial affiliation with Pharmanex. All this stuff that I put up here, I don't really put it up here to impress everyone. It's just how does a guy from Duncansville, Pennsylvania, lucky enough to be able to do one of my favorite things to do is teach colleagues. And that's because I get to be able to get plugged into some of these companies to talk about what's coming. Big disclosures tonight, right? A lot of these will probably be talking about companies, B&L and Alcon and Dompe. Just note that I have received speaker honorariums and advisory board honorariums. Before I make the most important comments here, remember that I do sit as a chairman advisory board for a healthcare registry. But with all that being said, this was independently prepared by me when I met with the medical science liaisons. And if I do mention a product, or if I do mention a company, I'm not showing any superiority, any bias that's out there. Joe and I are the owners of Optometric Education Consultants. Overall, everything has been mitigated with all the regulatory bodies that's out there. All right, here is my practice. I was just talking about how lucky I am. Here's my building, or I own the building with a couple partners in Duncansville, Pennsylvania. Yeah, normal exam lanes. This photo has been up, needs potentially could be updated since we now have dual screens in our office. We have electronic health records. We have an optical. We do contact lenses. Lots of fun equipment. But what I always like to point out is science is awesome. I was just at the OGS meeting, the Optometric Glaucoma Society meeting. They're showing neurons being grown and crushed and so on and so forth. You know, that's science, but that's not really good clinical science that we can bring and put into our practice. What I like to do is take all that and massage it down and just what can we do to be better? And that's what Joe and I's goal is every time we do a lecture. What can we do to make or help our colleagues in clinical practice? So that's the practice that I'm in. And with that being said, let's talk about this pharmaceutical resource matrix that's out there. We have our sales team. This can sometimes get confusing because we have the sales reps that come into our practice, and maybe sometimes we want to talk about off-label, right? Like, you know, when the Lotamax SM people come in, you say, I'm using it for dry eye. And they go, well, you know, it's really on label for this. Because when I do dinner programs, I've been trained to stay on label. Even though we think it might work, we can't promote it because companies have gotten in trouble with that. And that's why some of the times they'll say, hey, I'll get you connected with our medical science liaison. Those could be ODs, MDs, PharmDs, you know, masters, but they're there for education. They can talk off label. So when a lot of times whenever I build these lectures, you know, I hang out with the salespeople, but they're only going to tell you, you know, what they're trained in and what they're allowed to speak on. They might know that it could be used off label, but they can't get their company in trouble. So that's why they've hired medical science liaisons. You ever go to a meeting like Joe and I were just at the academy, there's a big booth, let's say for B&L, they got all this advertisement for MIBO, and then the little back corner they have the medical science, so that if something comes up off label, they can walk you around and you can talk to those medical science liaisons. So if you ever have a question about, you know, hey, I'm using it for this or I'm using it for that, you get down into the granular discussions. Then there's clinical research, there's marketing, and access. So I always tease my sales reps. I say, look, if I need to get you out of my office, I'll just start talking off label, because really they can't talk off label. They have to stay on label. So that's just the pharmaceutical matrix, and I wanted to review that. So Lots of things are happening, right? I mean, I work with all these companies. I walk through the exhibit hall. There's a lot of things happening with the bottle design. There's actually sprays coming out, like almost like an inkjet spray to the eye. The drops are getting smaller. Like what's going on? And this is really the backbone behind all that is that the reason for eye drop adherence, the side effects, the cost, the bottle, maybe lack of education. So, poor bottle design is a huge problem that's out there that's been identified, and that's why drop size have changed and so on and so forth. With that being said, most eyes can only hold 10 microliters of an eye drop. Most drops are 25 to 70. That's why no matter how good you are at putting drops in, if you're dilating someone, if you're dilating with proparacaine and then quickly following with tropicamide, well, then remember that drop size is probably 30 to 40, maybe 60 microliters. That drop of proparacaine, that's why it runs out because the eye can really only hold this 10 microliters, and then you follow it up after it's already filled with another 60 microliter type of drop or 30 to 60 microliter drop like tropicamide. So physiological tear volume anywhere from 6 plus or minus 2 microliters. Then there's capacity. Then we have reflex. Overall, drops are too big. And you've seen what Mibo has done. They've taken theirs down to, I think it's 11 microliters, 10 or 11 microliters. We'll see when we get to the slide that's out there. So this has been pretty cool. I've been using this in the practice. This is the nano dropper. I don't speak for them. I see them. Just saw Mackenzie out at the academy. She was giving me some of the latest research that's out there. And literally what she has done in her team is that they've taken just a cap or a dropper size and shrunk it down to 10 microliters. So we can see here that they've created a base and then this little rubber tip, and it shrinks down the drop. This has been really cool because there's some people that run out of drops, especially on that like latanoprost, and they squeeze the bottle, and this takes it down. And the studies are showing that we're not losing that efficacy. And you can see it for those glaucoma drops. There's a lot of and sustain, you can see here, glaucoma drops just from solutions to suspensions, and takes that and average lifespan of that bottle and takes it out to 2.6 times and not losing efficacy. So that helps save the money and decreasing the amount of drops and making it easier on the eye. So this is just, a study that was done, and they showed that there was really over here IOP, if you want to call it micro drops. And I pick on, nano dropper because if you take, a millimeter and cut it 1,000 times, that's a micron. If you take a micron and cut it 1,000 times, that is nano. And they call it the nano dropper. To me, it's kind of the micro dropper, but it's okay. It's a little play in words. I tease them a lot with that. And the reason why I bring that up, because there is nanotechnology out there, which we'll talk about tonight. But you can see here, even in this study, that the micro drop, right, and the conventional drops, and they're just showing it here with timolol, is that they took the medication and it ran the 207 eyes and 212 eyes, and there was really no change in IOP by using, if you want to say, the micro drop. But putting less medication did not affect the heart rate. It didn't drop the heart rate as much. So that was kind of neat of an outcome with this timolol. So the point is you're shrinking it down. The eye only holds those 10 microliters, and you put that drop on there, and that's just something to consider. And we'll talk about that here in a little more. So with that being said, I'm going to open up this question here. I'm just kind of curious that BAK is a preservative used in 70% of the eye drops. It's a quaternary ammonium compound that works as a detergent to kill the bacteria or the fungus. While BAK is effective, do you believe that it is toxic to the eyes and causes ocular surface disease? Do you out there believe that BAK is toxic to the ocular surface or creates an ocular surface disease? This is part of that interactive part. So please, if you're participating, find that polling question. If you look over to the right-hand side, you'll see chat, you'll see polls, you'll see notes. Click on that. Sometimes people that are on like mobile devices, I can't help you because I'm using a computer. Sometimes they say they struggle finding it, but I see the answers rolling in here.
Of course, no questions yet, Greg. People just getting
Yep.
acclimated. Somebody's saying hello, checking in, and we'll see us in Charleston. Looks like one of our attendees had his cat walk across his computer keyboard. That we're
Or
doing
maybe
well.
they, okay. All right. Looks like the majority, looks like the trend is in here. So I'm going to display the trend. And let's see, display. Here we go. We have 98% that are saying, yes, BAK is toxic to the eye. So I'm going to close that display. I'm going to close that question out. We have a nice amount of synchronous activity there. So thanks. And the reason why I bring it up, one of the things that I've been saying for the last maybe year, we kind of separated this. I was at the OGS last year and the year before, and they really started talking about the front of the eye, right? You have a whole society based on this axon, ganglion cell and axon that runs through the nerve fibrillary optic nerve, chiasm, all the way back to the lateral geniculate body. And we focus on that and talk about that. But then we started focusing a little bit about nutrition for these nerves and the trabecular meshwork and the oxidative stress. But then how much damage are we creating? And that's where you have this new concept out there of of interventional glaucoma, maybe trying to do things maybe early on, like minimally or micro-invasive glaucoma surgeries that are out there. So if you have a glaucoma practice, you have an ocular surface practice with the amount of SPK and maybe conjunctival changes that are occurring. And we know this BAK affects the trabecular meshwork and maybe affects the outcomes of our SLTs. And when you go for trabs that on fresh conjunctiva that has not been battered by the BAK and all the other inactive ingredients and the active ingredients, you don't get maybe as, in a tissue that has not been subjected to all this inflammation over the years, you get a better outcome, surgical outcome with these procedures. And there's at times where you're getting 6 to 7 drops of BAK per day. If you're doing, COSOP twice a day, a little BAK, now we're up to 5. And if you add in another medication, you're getting up to, in some of the maximally treated people, you're getting 6 or 7 BAK drops that are out there. And I don't think this is anything earth-shattering, but we do like to see that evidence-based medicine and studies being done, that the more drops that are out there that have BAK, the more likely you're going to have, the number of daily drops correlate with the severity of the ocular surface disease in a study of 516 patients. And then when you look at the drops, there is a majority of the medications that are BAK. And again, you could be putting these different various amounts of BAK depending on what you're using. Lumigan and Combigans and the generics and so on and so forth, Rocklitans. And there is a handful of alternatives. And in Europe, there's a lot of preservative-free eye drops used. And, I've been to Europe. I've lectured in Europe, heading to Europe this week. And when we go there, they always ask about, do we use preservative-free? Now, I understand the healthcare is different in Europe than the United States. So that's the answer behind where we are. But we all just said that we believe that 98%, but we have to then maybe try to convince our patients to maybe use the new, latanoprost preservative-free that we'll talk about. Are they willing to pay the $60, or do they want the free version or the minimal version of cost that has the BAK that's out there? So maybe a little bit of work that we have to do.
Greg, I was going to make a comment about Europe being very, very, if you go back just one, please, being very, very preservative free. And that may be the way to go. Unfortunately, all of our branded medicines came out preservative. And then when they went generic, they also have preservatives, and we're just a country that we have gravitated toward the generics. What is nice is some of these preservative frees are coming out in generic. Tafloprost is a generic. Timoptic and Ocudose, the last I saw it, that was frightfully expensive and just not usable. I think we're pretty close to a COSAP PF being generic as well. And of course, we have a generic latanoprost. So that one is not really well covered by insurance, but the other two seem to be doing quite well.
Yeah. And, as you gave me some time to think here, I appreciate that, my N of the preservative-free latanoprost is 3, and I'm bringing them back, and the patients, of an N of 3 are reporting increased comfort. Now we'll see what happens because they were samples. We'll see if they want to pay the difference here. So, time will tell. So there was a relief study done, showing, it's IUSA, the branded name for the generic latanoprost. And, there's a decrease in hyperemia, blepharitis, and the tear breakup time, increased comfort. So it is out there that even though it is a prostaglandin analog, even taking away the BAK can help out. And, that was reported in the DO studies, right? The DO studies, the dry eye workshop, came out and said the best thing that we could do for our dry eye patients was whenever artificial tears took out BAK, and that's why we have to be careful out there. The generic ones, hey, this is the branded, and this is the whatever Walmart, Costco, Walgreens, not gonna pick on any. This is, and it says it's the equivalent. It might have the active ingredients as equivalent, but we have to be careful because that BAK is in those generics in most of the cases. So
Greg,
another thing I like to go ahead, Joe.
I just did a quick GoodRx search for Timoptic Ocudose, and it is generic. And Timoptic Ocudose, I remember being in excess of $300. Right now, it looks like the range is 71 to about $130 for a 1 month supply. So I guess it's great that it is available, but the question comes down to, I don't think insurance is going to cover it, and what will people pay for?
Yep, that's what it's going to be. So, all right. Mechanism of action versus mechanism of delivery. So this is an important concept to know because as new things come out, I always try to figure out, is it a new mechanism of action or is it a mechanism of delivery? So as we can see here, what I'm pointing out with mechanism of delivery, Lotemax SM, 0.38%, which is TID, right? So less medication, less dosing. That's always going to make someone in pharmacology happy because less side effects with less percentage and less dosing. But what they did is here's the Lotemax gel, that 4 micron is as the bar here. You can see that this is as big as 5 microns at times, which could be seen by an OCT. Lotemax SM, they took it down to 0.4 to 0.6 microns. So certainly shrinking that up into that nanotechnology that's out there. There's various cyclosporin products which are changing that mechanism of delivery that we'll talk about, wrapping in a micellar type of, because it's great. Cyclosporin's great. It's just fat loving. You're dropping into a water environment. So that's why you're seeing the percentages go up, wrapping it into a new mechanism of delivery. Mechanism of action, Ropressa was really the newest in the glaucoma realm of a mechanism of action all the way back to latanoprost. Yes, there were other medications that came out afterwards, maybe the COSOPs and the TruSops and those different medications, but those were already used elsewhere. It really wasn't a new mechanism of action. Notarsadil was working on that trabecular meshwork. Mibo is a new mechanism of action. We're going to talk about Xdemvy tonight. That's a new mechanism of action. And some of them, as we go through tonight, will be a mechanism of action and a mechanism of delivery change. So when someone comes into my office, especially a sales rep, I try to figure out, are they trying to tell me that this is different because it's a mechanism of action? Is it a mechanism of delivery? Is it a combination? What are they going after? And once I figure that out, it made the conversations with the sales reps a little bit easier because, a whole bunch of latanoprost or a whole bunch of lotoprednol products have come out. Like, what's going on? Okay, well, they made it smaller, less dosing, wrapped it, into this, did that. So it just kind of helps me out. Okay, it's not a mechanism of action. It's still lotoprednol. They're just delivering it different. It's still cyclosporin. They're delivering or maybe changing the concentration. Mechanism of action, Ropressa. We never really had something that worked on the actin and myosin in the trabecular meshwork. Look at Xdemvy. We never really had a GABA chloride inhibitor paralyzing the Demodex. So that's a new mechanism of action. And years ago, whenever I was getting into pharmacology and lecturing with someone that I quite often lecture with, Dr. Tracy Offerdahl, she taught me to learn about receptors. And this is from my opioid lecture about how, the euphoria comes from plugging into the mu receptors and the dysphoria comes in plugging into the kappa. And it's, a lot of receptors that are out there. We have receptors in the brain and all throughout our body. And that's why we get constipation, in a sense, when we take an opioid. So the receptors are all throughout our body. She also mentioned that we need to learn about the immune system. And so we have in our innate immune system, we have, that's sitting there ready to act upon. And then we have our adaptive immune system, which is over here on this side. And this is now where you start getting that macrophage, that antigen presenting cell that grabs whatever it is, a bacteria, fungus, and then goes to the T cell, B cells, get that plasma cell. But if you look, you have all these interleukins. And then still kind of part of that innate immune system is that what we're talking about, the complement. And that's got a big play because of some of our new geographic atrophy. So we kind of have to understand the immune system because some of the biologics are going in and maybe playing around and trying to assist or block that adaptive immune system. So I put down here Ninja Nerd Science YouTube. If you Google Ninja Nerd Science YouTube and put immune system, I think it's an 8-part series, and listen to it. This I think he's a doc. He goes by Ninja Nerd. He reviews for the medical students, and it's really cool. He goes in here and maybe just starts with what's in red right here and just starts drawing this all out and kind of teaching what's happening. And he does it for a review for the medical boards. But if you want to learn the immune system and help out with pharmacology, receptors in the immune system. And here's just a classic example. And we're going to talk about teprotumumab. We do have this. I know this is a dry eye and pharmacology lecture, but thyroid does affect the front surface, and it gets fooled as a dry eye, but it's more of an inflammatory reaction. But we know that thyroid, what happens is the immune system becomes dysfunction. The T cells, B cells, and the plasma cells produce and break down in Hashimoto's or in Graves, produces a thyroid stimulating immunoglobulin or thyroid blocking, which goes and attacks the receptors. And the short of the story is, unfortunately, the orbit has receptors. Here are the receptors down here. Tracy was right. Here's the receptors. Here's the broken immune system. Here it is attacking now the thyroid in this picture, but it goes and attacks the fat, the muscle, because the fat and the muscle have these similar receptors. So it was about the receptors, and that's where teprotumumab came out, being a monoclonal antibody, being an insulin growth factor 1 receptor inhibitor, monoclonal antibody. There it is right there, monoclonal antibody, Tepezza. And here we are in the orbit. Remember, it's an orbital disease, and we can maybe get some dry eye, some inflammation, get fooled of a strange conjunctivitis when it's thyroid eye disease. We could be missing it. And here are the receptors that are the fat, the muscle, and we have the thyroid stimulating receptor, hormone receptor that's being produced. This is kind of that overactive immune system, that dysfunctional immune system. We have that insulin growth factor 1 receptor autoantibody plugging in, and this beta arrest, I'm not going to get too much into the science, but this all becomes one receptor. And when this plugs in and this plugs in, we get inflammation in the orbit and on the ocular surface, kind of creating that dry eye or inflammation. Well, teprotumumab comes in, and you'd think that they would have produced maybe a thyroid stimulating receptor type of antibody, but they made an insulin growth factor because this beta arrestin makes this all one. So if I could shut down either side, it shuts down the inflammation right here. So this is again understanding the immune system because this is a monoclonal antibody. The same types of antibodies that were being produced here in this adaptive immune system that goes and maybe kills the COVID virus when we had that novel COVID virus. So our body here, and then we're just using science and teprotumumab to kind of shut down this inflammation and maybe helping on that ocular surface. And then we had the fawns here. This is how he's being portrayed on TV now, as going after geographic atrophy. This is how Joe and I remember the fawns back in the day, one of the, popular TV shows. And we're talking about now the complement system. And here's just genetic testing about the arms and complement factor H. Complement factor H, genetic SNP. You've already got an overactive immune system in macular degeneration, and the complement factor SNP complement factor H tells the immune system to slow down. If you got that genetic SNP, then it can't slow down. It's already broken. The brakes are worn out. So now you got more macular degeneration, or more part of this this condition that's geographic atrophy. You can see C3. And again, it goes back to the immune system. Here's what we're talking about. You got a broken complement system. It's attacking the retina here. And you have to understand the immune system. You got to understand how some of these are working for geographic atrophy and going after this C3 inhibitor of this classic lectin and alternatives, going back and part of that kind of innate immune system, but the complement, and that's what Synfovre or Izervay, and Izervay is going after that C5 a little further down. So this is all broken and rattling that immune system that's out there. So we have ways to go after it scientifically against that evidence-based medicine or that evidence-informed risk-adjusted. All right, this is kind of getting all caught up, and we'll jump into some of the medications that are out there. Remember, biologics are totally different than small molecule. So when we talk about teprotumumab versus timolol, Joe was referencing timolol or Ocudose, or we can reference Lumigan or Bimatapros. That is organic, inorganic, small molecule medicine. When we talk about biologics, it's truly biologic or genetics that we're going after. So like aspirin is small molecule, biologics, we're talking, these are huge. And again, this is a picture right here showing in Dalton's, in a sense, how small aspirin is. But here is IgG used at times for myasthenia gravis. And you can see how large and complex it is. And that's why the cost of them is so high. And you're literally using living organisms, figuring out the DNA and running it through RNA transferase and making this and spinning it up, as opposed to organic chemistry. And I like pictures here. And again, here's aspirin equivalent to a bike. Here's an IgG, and the complexity to a Learjet here. And that's no joke when you talk to the pharmacists that are out there, the complexity. Literally taking a piece of DNA, plugging it in, making the proteins and twisting it up. And our first biologics that were out there were used actually in eye care, right? As vasoendothelial growth factor. And we can see what's happening here over the years, the evolution, Avastin, Eylea. And I want to point out again the importance of understanding that immune system. Beovu came out. That was by Novartis. There was a great medication that was to one injection can last up to 3 months. And when they did the clinical trials, 50% were able to do that 3 months after 1 year. But what happened? Where did it go? Again, understanding the immune system is that this Beovu, which was a monoclonal antibody, was creating these ocular inflammations. There was 1,000 reported after it was approved. And that's usually what happens. That's why I always encourage everyone to report a side effect to the company or to the FDA. And what was happening was ocular inflammations were occurring in 4%. There was vasculitis with the ocular inflammations at 3%. 2% were getting artery occlusions. So what happened? I spoke again, not to the salespeople, but to the medical science liaison. And now listen to this. This is why it's important to understand the immune system. When they were injecting this monoclonal antibody, Joe or I or any of the audience out there could already have an antibody, our immune system, for that antibody. And so that's what was creating these ocular inflammations all the way up to artery occlusions. So then they said, well, if you want to use it, we can test the patient for that antibody. Well, which retinologist is going to do that? And then the key is, remember, our immune system can adapt. Someone after you injected it can remake an antibody for that antibody. So that's why it all went away. So that's why it's important. Just my way of reminding everyone the immune system is important. All right. So that was about 30 minutes of kind of an overview of kind of where pharmacology is going, understanding receptors, understanding medical science liaison, understanding the immune system, and how important it is whenever we do pharmacology to figure out what's going on. So with that being said, let me open up this question here. I don't want to share that yet. And have you prescribed Xdemvy, lotilaner ophthalmic solution, 0.25%? Have you prescribed that yet for your patients? Yes or no? Really easy, interactive, synchronous, plug in. Joe, are we caught up, or do you have any comments to this point?
No, we're caught up. I just want to let the audience know it doesn't go in the chat. You need to go down below the chat to the poll icon, click on that, and that will give you the polls where to answer. People are putting their yes and no in the chat, and that's not where it goes.
Yeah, I can click over and see what's going on. If it doesn't answer, so I see some yeses. 98% is at the highest ever. Yeah, that's good. We tried to get that 100%, Kyle, but that was on the last poll. All right, let's see here. We did have 100% one or two times. So, all right, here we go. Let me display the answer. Looks like the trend is 20% yes and 80% no. Again, no financial interest, not a KO or not a speaker for them. But this medication, I've been pleasantly surprised by it. So that's why we're going to make it a lead off here for our talk. So Demodex infestation, collarettes are the kind of the pathognomonic sign. You have the eggs. You can see it building up here. You can see the redness. I like this photo. You can see the inflammation. And so this was kind of funny. I think Joe was in the room when this all happened. I was lecturing at one of our meetings. It might have been Disney. It might have been Pittsburgh. It was beginning of the year. And I'm talking about, how I have a success. I have a slit lamp camera. I take pictures of the patient and I say, look, this is Demodex poop building up on your lashes. We might want to get rid of this poop. And whenever they see it, explains why it's itchy and all this other stuff. This guy in the audience raises his hand and he said, hey, doc, I've studied this mite, whatever, when he was in undergraduate or in graduate school. And he goes, I just want to tell you that this mite does not have an anus. And I'm like, interesting. You always learn something every day. Love teaching. And so we kind of went back and forth. And I was like, okay, well, what's going on if they can't poop? Is this like vomit? And he goes, yeah, that's probably what it is. So whichever way you want to look at it, might poop, might vomit. This is what's building up on the lashes. And then that creates an immune reaction. That's what creates the other bugs to grow. That's what creates this kind of, we heard of the gut microbiome becoming disrupted and creating leaky gut. How about our lid microbiome becoming overgrown, There's food for them to feed off of. We have a disrupted ocular lid or ocular microbiome, right? We all know that we have Staph aureus and Staph epidermidis kind of living there symbiotically. Whatever study you read, 2 times more microbes than human cells, 10 times more microbes. I don't care what number it is. We know that we have more microbes in our body than we have human cells, whether it's 2, 5, or 10. And that has been disrupted when you see this on the eye. So we need to correct that. So lotilaner or Xdemvy 0.25%. This is novel, right? This, and why do I say by novel is that there has never been another allopathic or opposites cure Western medicine out there. There's tea tree oil that's more naturopathic that's out there, Cleridex that's out there with BioTrue that can help assist, but this is a little bit more efficacious and its mechanism of action, right? Because it's not the mechanism of delivery that's unique here. It's the mechanism of action is that it targets the parasite's GABA chloride channel. Now, let me tell you that humans don't have this GABA chloride channel, and that's what really now bumps up the safety of it. And that's what I really like about this drop too, is if you look, it's 1 drop twice a day for 6 weeks. Why I like it, it's not like a chronic medication that's out there. Xiidra is awesome, right? It works, but the patient's got to keep taking it to kind of do that immunomodulatory. Cyclosporin at a high percentage and some of these new mechanisms of delivery, they work, but you got to keep taking it. This is nice because it's really a 6-week. Now, my rep was just in today, and I told her, I said, look, I tell the patients that take the drop, 1 drop twice a day till the bottle runs out. I'm kind of glad it's a little bit overfilled because when it does run out, I tell them to run it and massage it into their lashes to help kill those bugs. But I tell them until it's empty. She would have to say, sorry, doc, that's off label. I got to tell you to take it for 6 weeks. You know, she's just trying to protect her job, try to protect the company so that they don't get in trouble and start running around going, oh, Dr. Caldwell tells them to use it until the bottle's empty. What a great idea. You can get the companies in trouble. And so they're not trying to be snooty. They're just trying to protect the company, protect their job. So 1 drop twice a day for 6 weeks. And this is the type of outcomes that you can get. You can see here that this collarettes, the vomit, the poop, whatever you want to call it, has built up. This person I wrote is somewhat symptomatic. Once I saw it, I said, how do your eyes feel? He was trying to explain it. He was getting down the path. Yeah, sometimes I itch at him. Sometimes they feel uncomfortable. So I showed him, he was 45, and I told him about this. He goes, I don't want that on there. Can you fix it? And I said, absolutely. So I prescribed the medication and had him come back 5 weeks later. Now, he probably wasn't on the drop for 5 weeks. This is whatever I was just getting into it. And I go through all the prior authorizations, so on and so forth. But you can see a dramatic increase or improvement, a dramatic improvement of losing the collarettes. And the patient had better symptoms. Now, this was probably after, this is a 5-week follow-up whenever I saw him, but he was probably only on the drops for, again, 3 to 4 weeks. You'd say, okay, maybe we should stop it. We don't want to stop it at this point because there's still the eggs there from these Demodex mite. And as they hatch, you want to be able to paralyze that GABA chloride channel. So that's why they go out to 6 weeks, or that's why I just say use it till the bottle's emptied. As you know, the FDA requires them to overfill that bottle, so it's going to last definitely beyond the 6 weeks.
You know, Greg, before you get too far, in a couple of comments and questions. One comment is the itching. That, when people complain about itching, look for the Demodex. My experience is that's also a common complaint when people have Demodex big cousin, psoriasis, which is crab louse. Now, these are much smaller, but the itching is a key diagnostic finding. Now, 2 questions came in, Greg. What's the cost to the patient for a course of Xdemvy?
Yeah, so I believe they are paying it down to 0 right now, or it's a minimal cost of maybe as high as $25. So what happens out there is with these new medications come out, whether it's Mibo is recent, we're going to talk about it tonight, Xdemvy, is that when the drug comes out, and if you, I don't know, Joe, if you want a good RX it, it's going to say, $3,000 or $4,000. Obviously, a patient isn't going to pay for that. We need the insurance company to cover it. So how the insurance company going to cover it if no one, there's a request for the docs, but the patients aren't paying for it. So they end up paying down for a first year or two the medication. So I've had anywhere from zero, I don't know if it's, I know maybe $25, $30 has been the highest. I do prescribe it. It used to be, I think, PhilRx, but my rep came in and she mentioned to me, use this one, Walgreens. It's affiliated. They're doing the prior authorizations. So I don't know, hasn't been that much. I don't know what the cost is. We're hopefully to get it covered by insurance, but we're just trying to get the numbers up or drive the numbers up.
Yeah, Greg, my knowledge is cost is about $1,800. And I did good RX it, and a price doesn't come up, but it says the company is committed to making Xdemvy affordable and accessible. Majority of patients will pay as little as $50, and I think I would agree with that.
Yeah, and I probably have an N of probably 35 to 40 right now because I really just see, as you'll see here, the benefits of this. So I want to kind of go back because when my rep was in today, we were talking about there was a paper at the Academy showing how this helps with meibomian gland dysfunction. I believe Ben Gaddy did it. It was kind of a little buzz within the Tarsus world that was out there. And, I was explaining, I try to make things simple whenever I lecture, is that when people complain of itch or burn, I usually ask, is it AM or PM? And I've narrowed it down that if that burn or itch is in the morning, it's usually bug related, right? Meibomian gland dysfunction, it could be burning in the morning. That's bug related, where the staph aureus, staph epidermis producing lipase shifts the pH of the eye because soap is forming. You go to sleep at night, the soap builds up, you get the burn, you get that pH shift. That's bug related. If they're itching in the morning, it's bug related, that it's Demodex. If they burn or itch in the evening, then it's probably more of an evaporative condition. And you have to address more, go evaporative, more aqueous deficient. I said that backwards, more aqueous deficient. And now they start to burn because the pH is in the evening. In the morning, it's kind of more evaporative, meibomian gland, bug related. So again, bug related if they burn in the morning. So when patients come in and I've got them with symptoms of dry eye or diagnosis, I usually say, where are your symptoms the worst? I let them think about morning, I'm going to go target the bugs. If it's the afternoon, I'm going to go more probably try to keep that eye a little wetter, maybe go after those Xydras and those Mibos and try to keep that eye a little wetter. So any other questions?
Yes. How often can a patient do the 6 weeks course of Xdemvy?
Yeah, so if you would ask that to the sales rep, right, they'd say that the only studies that they have out right now are 1 year, right? And I don't speak for them. And if I was doing a dinner program, that would be. This has been out for a year. I have seen patients out to 9 months. I have not had to use a second course, but I would not be afraid to use a second course if that came out. So
I I agree with you. And is hypochlorous acid effective?
hypochlorous acid can be effective. It's not going to be as effective as Xdemvy. So hypochlorous acid, it's kind of neat, right? Is that truly allopathic medicine? You know that people out there know that I do a little functional talk now, supplements, amniotic membranes. Hypochlorous acid, that's part of our immune system, right? When our white blood cells increase when you have an infection, the white blood cell, one of the chemicals in there is hypochlorous acid. Now, the hypochlorous acid now is a higher level when our white blood cells, so you get an appendicitis, right? Your white blood cells go through the roof, and now you have hypochlorous acid leaking out, and hypochlorous acid is there to help kill that back. It's part of your immune system. Well, you can't patent anything in nature, so that's why it's not really a drug, and that's why companies out there make it. It's more effective in something that is bacterial, not as in the Demodex. It does show some effectivity with a Demodex mite Hypochlorous acid is more for your Staph aureus, Staph epidermidis. Now that you know where it comes from, a white blood cell, it is bottled up. It does work, but it's not going to be as efficacious as Demodex, or I'm sorry, the XDEMVY when you're using it for Demodex. And the same thing with tea tree oil. Tea tree oil is very natural. It's a good alternative, but it's not going to be as effective.
Another question came in after a 6 week course. Are there preventative measures to reduce reoccurrences?
Yeah. So again, try to figure out how this patient got here. Is it, are they not eating, sleeping, exercising? What's their lifestyle? That's kind of, to me, it's kind of like more of a leaky gut type of thing. Why is their lids, having this microbiome issue? That could be some of the chalk, but we kind of touched upon it with the tea tree oil and the Claridex. They do make the wipes, they do make the foam. I have the foam in the office that I will use a Claridex foam maybe once a day for the next 3 or 6 months, follow them up and see if that helps keep them clean. But I can tell you, Joe, that I've done both and now have followed them up 6 months later. Obviously the Claridex people look really, really clean when they come in, but I haven't seen a lot of much overgrowth about 6 months out when the patients come back when the follow-up using the XDEMVY.
I think people just need to be made aware that they have to pay attention to their lid hygiene. They think that they're washing their face and they're good, but because of the orbit, they're not really getting to the eyelashes very well. Even if they close their eyes and soak things up. So, as you mentioned, the Claridex wipes, it's probably good to do that. Probably maybe once a day, with attention to the lids and lashes, not just washing your face, because the setback of the orbit is meant to protect the eyeball also, but we don't clean it very well.
I don't want to go in there to make it too functional of a talk because I can really get into a rabbit hole. But, like diabetes, you start seeing diabetic retinopathy, that's end organ disease. It's diabetes. Maybe we can do a little bit better in telling the patient to burn off their fuel. Maybe they don't always have to take a metformin. Maybe they should look a little deeper at what they're eating and so on and so forth. To me, when you see Demodex, this is the body talking to you. Why is their lid microbiome dysfunction? And sometimes it could be. I have patients come in, yeah, they had cancer. Well, okay, I understand what's going on now. The body really didn't focus on your eyelashes, and the Demodex got a little bit out of hand. So, yeah, so it's kind of think of it from the bigger picture out there for those who are listening. So here's our patient. Here's October 30th. That's when it was written. And I put this all in here because you go through the prior authorization and kind of showing you, again, after 3 weeks, a significant improvement, especially over here in this left eye. But you can see after the 8 weeks, full treatment, these lids are pretty cleaned up that are out there. Now, with that being said, this is my patient. That's the one that was somewhat. So let's kind of listen to this video. All right, everyone, I'm here with Michael, and Michael's given me permission to do this video. We can see here he's got a pretty good amount of Demodex blepharitis. This is a little bit over 3 weeks, maybe right at 3 weeks. You can see that he had a pretty good overgrowth. He's got a nice improvement on the right eye. Here's the left eye, and then a really good improvement over here on the left eye. So 3 weeks, we got 3 more weeks to go. And here's Michael, and we were chatting about, Mike, why don't you just tell me how your eyes felt and how they feel now?
At first, it was always seemed like there was something in my eyeball. I wanted to scratch them, itch at them, and everything. And with now, throughout the day, it seems a lot better, and I don't want to mess with my eyes as much anymore.
The drop is twice a day. We're going to do it for 6 weeks. Does the drop sting at all? Does the drop irritate your eye at all? Is there anything with the drop or is it just a comfortable drop?
No, it's a very comfortable drop, no irritation whatsoever.
Great, perfect.
Yeah, it's good. I love it.
All right, perfect. Yeah, easy treatment. It's not chronic. We'll be done with this in a few weeks, and who knows? Maybe we'll come back and we'll treat it in a year or two. But at least we got a solution for it.
Yes, absolutely.
All right, bud.
That's great.
All right, thank you.
Thank you.
So I always like to put some testimonials in there. This was a neurologist that came in. This is just a video. We kind of geeked out about the GABA chloride, but the trick is you have to have the patient look down. You can see I'm having them look down. I pull their lid up. I kind of move the lashes around. You can just see the amount of collarette, I'm not sure if that's a millimeter or 2 millimeters long, but you can definitely see this is a condition that's going on. I guess I started with his left eye, came over to his right eye there. And so, that's look, it's all the buildup, right? You can kind of tease the patients, you kind of hear what I call it. I don't have to say it over and over again, but here we are now, just 3 weeks and hitting that GABA chloride, and I've used the tea tree oils years and the Abenovas and the hypochlorous acids that are out there. And you can see here, he's got a little bit, still has some lid neo going on, but you can see here, compared to what it looked like, we've cleared that up just in 3 weeks, but we're going to go that full, maybe it is 7 weeks because it's a 42-day, it's 6 weeks, 7 days in a week. 6 weeks. It's a 42-day whenever you do the prior authorization that's out there. All right, let me do another polling question. And Joe, is there any other questions going on?
Let's take a look.
I have as the polling question as you're looking, I do or my practice does intense pulse light, IPL. Yes or no?
Question is, how often patients ask how they've gotten this and is it contagious? How do you address it?
Yeah. Is it contagious? I tell the patient no. I don't think you can literally, if I had Demodex and wiped it on Joe, to me, it's a sign that their immune system is not keeping these. Remember, we have 2 to 10 times these microbes living on our body. And our immune system and our body's, balance is supposed to kind of mediate all this. So when a patient says, how did they get it? I say, well, look, these are just normal critters, normal bugs, normal. We need the Demodex on there, but they are overgrowth. They're overpopulated. And I'll go into it. I'll say, look, I'll go down any rabbit hole you want to go into. Is it your diet? Is it your exercise? Is it the Western diet that we have that's out there? Do you have leaky gut? Sometimes they'll be like, oh, geez, I had cancer, this and that. And those things will kind of surface as time goes by. But it's an overgrowth of a normal bug that is living with us, I guess, synergistically, what word am I looking for there? Symbiotically with us. And it's an overgrowth. So I don't tell them that they're dirty people. It's just that to me, it's their body talking to us saying your immune system isn't doing what you're doing.
Yeah, I don't think it's really clear if it's parasitic or not, or saprophytic. For the drop, you just have them close the eye and soak in the lashes, or you put it in the eye, into the cul-de-sac. I know how I recommend, but Greg, go ahead.
Yeah, so it's just a drop that goes in. And again, we talked about how the drops are larger. It's a 30 to 60 microliter drop, so it's going to run out. So into the cul-de-sac, close. What comes out, massage into that base of the lashes where the condition is. And that's why I always show every patient of mine, I take a picture with my camera and we document and show them so they can see where the problem is and they can massage it in. But Joe, go ahead.
I do the same thing. Just a drop in the eye, it'll get on the lashes. You don't have to work it in to be effective. Are Avizia wipes as effective in the maintenance of blepharitis as Claridex wipes, Greg?
I don't know what's in Ivizia wipes. If you want to look it up, Joe, and see at some point what's in that wipe. I don't know what's in that wipe. I have them at the office.
Yeah, I'm gonna help out. I'm gonna say it's probably as effective in blepharitis, because it's a good is a good wipe, and the mechanical friction and action is what's really doing it. Question: could their vitamin D levels be low for the Demodex people?
Yeah, absolutely. I mean, we're going back now to functional medicine, trying to figure out what's going on. And, is it just the vitamin D, or is it now the vitamin D is just one sign that the whole antioxidant system is disrupted? Because vitamin D is one part of the whole antioxidant. It's a hormone actually out there, believe it or not. It's produced by your skin. Yeah, I mean, the answer is yes. Yeah, you can get down into that rabbit hole for sure. All right,
And
what's in it? Purified water, PEG number 8, polysorbate, glycerin, triglycerides, alcohol. So, like Joe said, it sounds like it's going to be effective, but more for the blepharitis.
Now, do you have a patient do Avenova or hypochloric lid wipes first and then Exdempi, or straight to Exdempi?
Right to Xdemvy. I'm going for something that's
I
potent. It's the most potent that's out there. So,
I agree.
all right. So we have 10% of our patients on here, or 10% of our attendees that are got IPL. So there's a big buzz out there with it. I just was kind of curious. We have it in our practice. And what I want to show you here is Larry. He's a 73-year-old Caucasian man. He wants his fourth opinion on his itchy, watery eyes. Right. So I asked him, which is it? Where is it? When's it worse? Doc, all day long. I wake up, my eyes water, and they itch and they water and burn at the end of the day. So that tells me, right, maybe we have more than one problem. Maybe it is something that is bug related in the morning, and something that is more of a aqueous deficient in the afternoon. His past ocular treatments, he has tried solo. That's the key here where I want to go with this. Sustained Ultra, Ivizia, Restasis. He's done these warm soaks. He's pre-diabetic. He's diabetic. He's, where he's on metformin, Mounjaro, Farxiga. He's got all these medications. We're talking the metabolic syndrome here. Someone just mentioned vitamin D. He's on aspirin. Then I do the hand scanner in my practice, and his Raman score is 27,000. That's a D, right? We want people to be about 50,000. I exhale when they're in the green at 40,000. Yellow is 30. He's down at 27. He's a D. He's got a lot of oxidative stress going on. And let me show you a picture of Larry here. Here's Larry, my 73-year-old. We could see rosacea. We see Demodex going on here. We look at his meibomian glands. He's got meibomian gland dysfunction here. His meibomian glands are dropping out. They're shortened. This one seems to be pretty robust. These are okay in this area. These are shortened. Meibomian gland dysfunction. He has Demodex. He has rosacea. That's why going single agent is not going to fix this person, right? He has a serious, complex, more than one. So we have this lengthy discussion. Larry, you have failed whenever we try and do Sustained Ultra or a Restasis or a Xiidra or a warm soak and Restasis, because you have a very complex, you have a systemic association. You have metabolic syndrome. You're pre-diabetic, you're diabetic. Which one is it? You have environmental involvement. You have lid microbiome or dysfunction. He has Demodex. He's got nutritional association. His score was down. So I said to him, I said, look, I don't mind taking your case here, Larry. And he's like, I want you to take it. You were referred to me. So I said, we're going to address your Demodex. We're going to address your nutritional issues. I'm going to put you on some fish oil. We're going to put you on a supplement that's comprehensive, going beyond lutein and zeaxanthin, working on his immune system, supporting the immune system, supporting the cell membrane, supporting from the inside out. We'll continue the Ivizia. And because of his rosacea, we're going to do some IPL. He's got some dry eye, so I have the Luminous at my office, but you could use, they all kind of have this kind of dry eye settings. And I went out and I targeted some of his rosacea. So he was all in to try to get him fixed up. So December 18th of last year, we wrote the prescription. He comes back on January 22nd. In the meantime, he was 12 days after his first IPL treatment. He's been on Xdemvy for 3 weeks. I had him on Life Pack and fish oil, and his score has already gone from 27,000 up to 32 in a 4-week period. So we've got a lot of treatment going on here, and we can see that this is my point, is you have to have them look down. When you look straight, you might miss it. When they look down, you'll start to see the critters and the vomit, the poop that is building up on their lashes. And you can see just now the IPL, intense pulse light, is going to treat and kill some of the Demodex. The Xdemvy that's there. We're starting to try and neutralize or help out with the fish oil and the antioxidants, reduce some of the inflammation. So which one was it? It's in allopathic medicine. We'd like to be kind of do this, and this is what happens. When you have these chronic complex, it's more of a strategy that's out there. That's what I've learned in my functional medicine. It's more of a strategy. And Larry was more of a strategy. Now, look at this. This is amazing. This is him before his first treatment. This is Larry after one treatment. Look at the rosacea starting to calm down on his face. Look at his eyes starting, look at the skin starting to improve. This is before his second treatment. Now, this is before his third treatment, right? So this is after, this is before his second. This is, look at the rosacea, and I started targeting him a little bit closer with the rosacea to quiet this down. But look at his eyes. Look at the lid margin starting to settle down, starting to swell. Look at his skin starting to improve here. And I'll show you what I mean by that. This was his before, and this is his after. This is his before. This is his after. Look at the skin. Look at the wrinkles. I'm not even doing RF, radio frequency, on him. I'm just treating his disease process in a strategic way here. And so I walk him out after his third treatment. And I forgot to tell the front staff something like, hey, I have it down for 3 weeks, but I did a lot of work today. I wanted to run back and say, I have 3 weeks written down. I wanted to do 4 weeks, let the skin kind of heal, let it regenerate, let all the other strategies that I'm doing kick in. So I literally walk back, come up, and 2 front desk girls are crying and Larry's crying. I'm like, what just happened? I walked up. I said, I'd like to see him. Back. Forgot that I had 3, went to the back, came back and said, oh yeah, I had 3 written down. I went 4. Everyone's crying. And the staff said, to Larry, he said, they asked him, how you doing? How are your eyes doing? And Larry started to cry. He goes, this is the best my eyes have felt. And he started crying, and they're not watering. He's able to now, quality of life has improved. And he started to cry. The girl started to cry. And so now I had to kind of get everyone, it was good tears of joy. So it was good to see the staff seeing the stuff that we do. Ooh, what's this? Cancel. All right, I'm getting an update here. That we do is very positive for our patients. But you can see here, this looks pretty cool here. So nutrition does play a role. His scan score is up. He's feeling better. His blood work is actually improving. That's kind of funny. Maybe he's not going to be on the Demet or on the metformin, but we're not here for that. We're here to show you now. Look where he was. Look where he is today. And so we're, again, on the 5th treatment, I got a vascular filter. I started closing this down. Just I wanted to get rid of the rosacea. But look at how well he improved here. All right, I think we had enough Xdemvy here. Let's see. Let's move into some other stuff. Xdemvy, these are the mites that are out there. They can create mechanical, bacterial, chemical issues. You can get disorders of the eyelashes, meibomian gland dysfunction for sure. Lid inflammation, you can get corneal manifestation, you're disrupting everything, inflammation, conjunctival cornea. Demodex does play a big burden. We have itchy eyes 55% of the time. So as Joe mentioned, itchy eyes is usually big. Then you have dry eyes, foreign body sensation. The key is we have an easy treatment out there. It's preserved with sorbate. It is not BAK. It's gamma-gated chloride channels that's only found into the mite. It's lotilanter, 0.25%. It's a multi-dose bottle. It's specific for Demodex blepharitis. It paralyzes them. It doesn't allow them to live, and it's twice a day only for 6 weeks. I usually use it till the bottle is empty. All right, Joe, any other questions, any other comments so we can move on from Demodex?
I think we can move. I'm going to look at the chat again, but I think we can move. Oh, hold on. Do you think hordeolums are related to stressed immune system, poor diet as well?
What was that, hordeolums?
Yeah.
Yep, absolutely. Yeah, it kind of broke up when you said it. The answer is going to be yes, right? Again, to me, it's the disruption of the ocular microbiome. It's your body talking. Now, I'll treat them with azithromycin, so on and so forth. They start coming back and start getting multiple hordeolum or chalazion. we got to scratch our head and figure out what's disrupted.
What role does doxycycline play?
Doxycycline plays a pretty big role that's out there, but due to some of the side effects from it, I usually would do a low dose, 50 milligrams, high dose, 100 milligrams twice a day. That's therapeutic. That's killing the bug. That's more Lyme disease treatment. Maybe it's slipping my mind. Staph aureus resistant, MRSA resistant. You get up to 100 milligrams. So low dose, 50 milligrams, but with that comes, complications. Now you got gut microbiome issues, but it does work. I speak on it, I use it, but I've definitely has decreased over the years as these other more efficacious treatments have come out.
Now, for the patient you treated with the Optilite setting first and then treat with the rosacea pre-settings on the luminous device?
Yeah, dry eye. If they're familiar with the Luminous device, I just did the OptiLight dry eye and then followed up with facial rosacea, mild or medium. I'd have to go back and look at what my plan was and did 2 passes. It was probably medium and shallow, 2 passes each with the selected filters.
We're good.
Okay. All right. The deeper vessels that I went back later, I used the telangiectatic vessels to close those down. So, all right, we'll do an IPL lecture sometime once I get a little bit more feeling like I should talk about it a little bit more in depth. All right, let me show you this one. I just resaw this one back at the Academy, Rinsada. This is actually a retinologist in Pittsburgh that's been traveling around. I've seen him at a couple shows. This is for dry eye. It's basically, and we'll go through it pretty quickly, power washing the biofilm. It's first in its class. I had it done on my eye while I was down there, and they did it without anesthetic. That's how they recommend it. It was pretty uncomfortable. I'm used to it being an eye doc, I'm not sure, but they want the patient to feel the immediate release. These biofilms, and now what they're testing is to see if it's building up like heavy metals. And you're literally putting this, and I'm going to show you here. It's got 2 ports one on the inside or 1 or 2 on the inside, on the outside. And you're literally pushing this saline through and power washing the upper fornix, which is twice as big as the lower fornix. So it takes 3. You do 1 to the upper lid, right eye, left eye, and then you do 5 cc's of the right eye and 5 cc's of the left eye. So 3 syringes. Obviously, you can charge what you want. You can buy them, so on and so forth. But it's just a nice way for that dry eye treatment that's out there. And it's really going after the biofilm, right? So we see all these treatments that are out there for biofilm down here at the lid margin. But what he has shown is that and I thought this was kind of funny. He was talking about, when I talk about the immune system, here's your aqueous deficient, here's your evaporative disease, very simplified, that's how easy. But this point in here is just showing you the immune system. Here's your interleukins and the goblet cells, and everything just becomes disrupted that's out there. Biofilms, they're all over the literature, and blepharitis and dry eye disease. You can see what's happening with the biofilms and how it creates another disruption to the lid microbiome. And I thought this was a pretty neat slide in talking about biofilms. We have things that we can go in and remove and treat the blepharitis and meibomian gland. We can heat up the glands and do IPL and squeeze, but we really don't have anything that's really great for those biofilms that are out there. So this here is basically showing that the biofilm starts just outside the lids, but grows all the way up into the fornix. And you can see that it can block some of these, the lacrimal gland orifices. You have the Krauss and Wolfring, blocking some of the meibomian gland. And that's why biofilms just are not good, but we don't really have a great treatment that's out there. I thought this was kind of funny whenever I was looking at the slide deck about, again, I'm supporting my support of the immune system here. You can see the immunoglobulins here and the T cells and the B cells, and then how it creates all this inflammation. But this is me doing it down in at SECO, actually. It's actually kind of cool. There was a whole bunch of banners in the outside, but the iPhone, I was able to click on and pull my image out to get rid of to be COPE compliant, all the different types of symbols that are out there or all the different logos. So this is me doing it on one of the reps, and this is pushing the saline through here. So you can see that it's the drawback if you're going to do it correctly is you stick it up underneath the upper lid, and you got to kind of force down to not just drip drip. You're actually just pushing down and power washing that upper fornix and blowing away, in a sense, that biofilm that's out there. So I said, how much are people charging? I said, look, I'm not trying to do collusion or anything out here. And you can get them for about 25 bucks a pack, and people are charging up to or around $75 to $100. And the patients are feeling pretty comfortable. Again, upper one, upper two, and then half down below and half in the other. Again, I have no financial interest. I thought this was kind of cool, and I had it done to my eye, and it still feels pretty decent on my right eye that had it done. And again, Demodex loves these biofilms. It's what it helps feed off of, and we're using, an allopathic medicine like, Xdemvy, and then we can go in and power wash away all kind of literature out there between disease and Demodex and bacterial dysbiosis that's out there. So kind of a cool way of just in a naturopathic way to kind of just power wash that fornix. All right. Let's open this question up. I'm just curious. Have you prescribed Mibo yet since it's been out?
And while those are rolling in, Greg, what's the best omega-3 for blepharitis?
There's really not, to me. I've done the research out there in the omega-3s. I guess if you want to get down into triglycerol or ester-based or ethyl-based or resolvent that's out there, you want the triglyceride form. To me, you want a quality company. You want fish that are sardines or anchovies that are eating the algae. You don't want a company that's squeezing a whale, for lack of a better term. Whales eat a bunch of, smaller and bigger fish, and then they build up the lead and the mercury that's out there. Here's the misconception as this is rolling in. The omega-6s get thrown under the bus. The body likes yin and yang. We have the sympathetic system, the parasympathetic system. We need to exercise it. We need to sleep and recover. Yin and yang, it's all over the place. We have water-soluble vitamins, fat-soluble vitamins. We have omega-6s that's in the American diet to get blamed for being pro-inflammatory. They need to be balanced out by the 3s. The 3s are the anti-inflammatory, the pro. Our body needs both. The problem is we get too many 6s, and that's why you need to balance out with the 3s, is to balance out what is that yin and yang in our body. I take about 2 to 3,000 fish oil milligrams of fish oil a day, just the way I travel. And I'm not by you. Every time I go visit Joe knows what I like. Hey, Joe, let's go eat some fish. He makes it. Joe makes a great salmon. Joe, you're going to cook that salmon for me. And then he gave me the recipe. Or we go out and I get it blackened. I get it this, because I live in Pennsylvania, where we put on iceberg lettuce, which isn't healthy, steak and French fries. So I take a lot of omegas. But, there's not but when you get into supplements, it's a different brand. But fish oil, there's a lot of good ones out there. All right. Have you prescribed it? Yeah, we're getting there. 30%, a little higher than the Demodex, or that little higher than the Xdemvy. We're at about 30% here. So same process. It's, it's a brand new drug. It's a medication. Coverage is an issue. And so you can prescribe it to, I think it's PhilRx. I have everything written down in my office when I want to prescribe it, and I go right through the electronic process. Mibo's really cool. I like talking about it. Perfluorohexyloctane. It's 100%. It's by Bausch and Lomb. And, oh man, I still didn't update this. I have to get this to QID. This is from the Demodex down here. All right, it's by Bausch and Lomb. It was approved May of last year. It's been out over a year. Its indication, I like it. It's for the signs and symptoms of dry eye disease. So that's nice, because it covers now the meibomian gland side, the evaporative. We got the aqueous deficient. It's unique. It is water-free. That means it's not going to burn. It's sterile. It's a non-steroidal. It's a single agent. Look, 100%. Well, if it's 100%, you don't need a preservative that's in it. It's very unique. It spreads. It's got a low ocular surface, but then it sticks really easy. It's got that lipophilic portion to it. It's an eye drop and it's QID. It's QID. I have to fix this. It's not BID. That's out there. It's a single ingredient, no inactive ingredients, water-free, preservative-free. It mimics the natural meibum of the eye. It's targeting evaporation, which is 86%, and it's been shown to last in the eye up to 6 hours. And now check this out. 11 microliters that's out there. So here they actually now are putting an 11 microliter drop. Here's the issue. We're so used to just giving drops to patient. This one, you're going to have to explain. Listen, you're not going to feel it. There's no water in it. It doesn't have a pH. There's no water, so it doesn't have a pH. It's very small. The patient can squeeze the whole bottle in their eye, literally trying to figure out if it's getting in there. So be careful using this MIBO. It's targeting the major part of dry eye, evaporative, right? So every time we go and we prescribe, our, Ivisias or our refreshes that are out there, they're nice, but really it's only 14 are truly aqueous deficient. We have a mix at 36. Most of our patients are evaporative, so they're really going after the majority of our patients here. I like this slide here. It reminds me that when you have the disruption and the lifestyle, that you get evaporation, and then you get desiccated stress, tissue damage, inflammation. I'm going to go forward here, and I'm going to show you a slide, then I'll come back. Now, take a look. This is one of my favorites. For those that are out there, what I should have put as a polling question, how many of you out there are doing tear hyperosmolarity or tear osmolarity, looking for the hyperosmotic tear? This is what happens in hyperosmotic tears. If you look at a tear film that is not evaporating, as they're showing what MIBO is doing here, you have all the different mucins and electrolytes and chemokines and cytokines. Remember all the interleukins that are out there? They are in the tears and they are properly suspended by aqueous or water. What happens is if our lipid evaporates off, now things become condensed. It's like salty water, right? If I had a glass of water and I let it sit for a week and the water evaporates, it becomes saltier because it's becoming more hyperosmotic. That's what happens here with the tears. So if I was doing this person's tear osmolarity and this person's tear osmolarity, this one would be perfect and this one would be hyper. Now, I just mentioned the body likes to be in balance. Hyper versus hypo, yin and yang. The body's going to say, geez, my tears are too salty. Where's it going to get the water from? Well, it's not going to get it. Maybe if you're in Joe's, where he lives down in Florida, maybe the humidity of Florida can now help keep these tears and pull the moisture in. Probably not enough humidity in Florida. So it's going to now pull it from the cornea epithelium. You see how they're showing here in this cartoon, the stressed epithelium? These tears are hyperosmolarity. They have too many solutes in them, the interleukins, all. And so the body likes to be in balance. It's going to pull it from somewhere, the cornea and conjunctival epithelium. Now that is your desiccated stress. Then you get tissue damage, inflammation, and that's why this is spinning all around. That's what happens when you have evaporation. Evaporation creates a very hyperosmolar tear, and now it puts the stress on the epithelium. So what they've come up with is perfluorohexyloctane. Let me walk you through this molecule. There's 14 carbons here. Some are fluorinated. All you need to know is when they're fluorinated, it loves the air. Some of them are hydrogen. Hydrogen loves fat. So this molecule loves to be in two places at one time. It likes to be in the air and it likes to be in the lipid. So, and it's nice because you've got this 8 that are anchoring in the lipid and you got 6 carbons that are in the air that are fluorinated. What a unique molecule that truly helps with evaporation. It's been in Europe for years. It's been called Evo Tears. It's been over there. I grabbed a bottle 2 years ago when I was in Germany, and I grabbed a bottle 2 years ago whenever I was in Poland. Over in Europe, it's over the counter. I was able to walk into a pharmacy, give me a bottle of Evo Tears, and put it on my credit card. In the United States, it happens to be prescription. But the beautiful part about it is it's a very safe medication. Zero serious ocular adverse events, a low discontinuation rate. It's not going to burn because, the patient, there's no pH in it. And there was one ocular side effect that was greater than 2% blurred vision. You're putting a drop in the eye, even though low surface tension, greater than 2%. 2.1 complained of blurred vision in a study of 1,200 patients. So not too bad. Now, this is one of their slides that I got from the medical science liaison promoting the comfortability, but when you're in clinic, that's a drawback in a sense. You're going to have to, I was fooled by it. Now it's my job to come out and talk to our colleagues is that the 11 small size and it doesn't burn, the patients might not know. So it's a little extra teaching going in. When I was talking to Mackenzie out at the exhibit hall at OGS just last week, she's actually made a nano dropper for it to make 11 microliters come out 11 microliters, but it's a bridling system so they don't squeeze the whole bottle. So for those that are having trouble with it, you can use the nano dropper. Again, I'm talking about, I thought it was really cool. I have no financial interest in that company. I don't speak for them. I'm not on their speaker bureau, but I just think it's a pretty cool concept that's out there. Joe, any comments on MIBO or any questions?
Two comments on MIBO, and one, let's take a step back. The hand scanner. What hand scanner are you referencing for the IPL patient?
Yeah, I use the Pharmanex hand scanner. There are basically two hand scanners. There's one by MacuHealth. There's one by Pharmanex. And you can even go a step further. They all measure carotenoids. One is the MPOD. My point is, I don't care how you measure. Raman spectroscopy is a little bit different than reflectance. It's not influenced by skin color and hemoglobin. That's why you got to squeeze the finger, but still they both measure the amount of carotenoids, and so does an MPOD. My point to when you do the scanner, the functional doctors, when I go to my functional meetings, have taught me if someone is low in carotenoids, the way you interpret these tests, because they have them in functional medicine, is that if you're low in carotenoids, which is part of the antioxidant system, you are low in all antioxidants based on skin and blood work. And we should use the biomarker to help and fix the whole foundation. In optometry, we say you're low in carotenoids, and then we say you're low in lutein and zeaxanthin, and that's what we build up, which is not a bad thing for the eye and for the foveal pit, but the eye deserves more. So long round out stories. I use the Pharmanex hand scanner. There's other ones out there, so I'm not promoting anyone. Remember, I disclosed that I am a non-salaried affiliation with Pharmanex. But to me, it's more important that you interpret the test and then treat the test, treat the person appropriately.
All right, couple of MIBO questions. How is the price of MIBO compared to other dry eye prescriptions?
Yeah, again, it's one of these new medications that are out there, right? So it's going to go to one of those specialty pharmacies. I think, I haven't had a patient pay more than $50 in the commercial side. I think it's even free. Medicare, they've got it figured out that if you ignore the prior auth, just talk to your sales reps that they'll even get it for free for the first bottle. After that, maybe in the federal programs, Medicaid, Medicare might get a little high and dicey, but it always is in the commercial side is where they fix things first. So, I've had people pay $0. I think I've heard someone say they paid $30, maybe $50. But that first one is always, the easy one to get. In the commercial side, they've made a lot of penetration and success. It's going to be on your Medicare side and in your federal programs where you may have that second issue. Joe, do you have any experience with it?
Uh, yeah, I feel about the same. Of course, if it's not approved or reasonable, they don't get it. I mean, they don't take it. But $30 to $50 is exceptional. Compared to other dry eye products, you got Restasis, which is generic. You've got Xiidra, which has been out there for quite a long time, so they've got a better penetrance. This is very similar to Vivi. Greg, is Mibo a forever chemical?
Um, Perfluorohexyoctanes are all forever chemicals. However, I got to geek out with a forever chemical expert. So here's the short of that whole conversation. Forever chemicals is a huge category. There are some that are bad, that are like non-stick coatings, things that were like fire resistant and fire retardant, and they are getting into the body, creating bad side effects, bad for the world. This is on the good side of the perfluorohexyl, if you want to save it forever. I'm not sure if they'll be classified as forever. I have to go back and remember the conversation. But there are some that are toxic to the environment in the body, and some that aren't. And this falls into the not toxic, at least I'll say, not to this point, right? That has been identified.
Can you use Mibo 30 minutes before wearing contact lenses?
Well, the package insert will say because it lasts so long, 30 minutes, you put the drop in and you have to wait 30 minutes. They're actually doing studies right now. My colleagues that were out there when I was in Indianapolis, talking to colleagues when we were out to dinner, they're actually doing studies using it with contact lenses to try and increase the comfort and decrease some of the complications. So if you're going to go strictly by what the company says and you go to a dinner program, it's going to say 30 minutes, put the drop in and wait. And if you're going to do it 4 times a day, take the contact lens out, put the drop in, wait 30 minutes. That's going to be the sales. You could talk to the medical science liaison, but we have colleagues that are putting it in right with the contact lens.
And can you keep Mibo in the fridge so they feel it going to the eye, or is it just too small a drop?
Yeah, that's a good suggestion. I have done that with success. You could put it in the refrige so that's a little bit colder so that they can feel it, and it doesn't disrupt the chemical.
You're caught up?
Fantastic. Great questions. All right. I'm gonna go through these pretty quickly. Cyclosporin, it's been out for years. You can see what Vivi has done here. They've raised it up, increased it. And so this is really not a mechanism of action change, right? So we didn't really go into, a new type of medication here. It's still a calcineurin inhibitor, just like Restasis, but now they have their own perfluorobutylpentane, totally different. It's a little bit shorter. This is, I think, like a 8 to 10 carbon. So you don't get that evaporation that's out there, but you do help, that you don't get to prevent that evaporation like Mibo, but it has that unique characteristic, no pH, water-free, it spreads rapidly, and again, that smaller size that's out there in twice-a-day dosing. And with that, see, I don't really have a problem with cyclosporin. I was never a Restasis speaker. When it was with Allergan, they wanted me to speak on it, this and that, and I never would. I would speak for Lumigan, I'd speak for Combigan and Alphagan. I thought they were great products, but I just couldn't, it just wasn't high enough. When I would use it, I'd say use the whole tube all day long because it's a fat-loving molecule, it wouldn't penetrate the tears. So if I go to a dinner program, I'd be talking off label the whole time because I would tell them to crack it off and use the vials, 2 vials all day long to kind of force it in. And you can see here that Vivi has and Harrow have kind of tried to work around it by putting it in this mechanism of delivery, this perfluorobutylpentane, and then making the drop size smaller and adjusting the preservatives and so on and so forth. That's out there. So that's Vivi, that's cyclosporin. And then now we're back to the nano dropper, which I think this is really, really cool. It's compatible for a lot of drops. It's taking these different bottle sizes, giving it a nice bullseye. You screw this onto the cap size. I have these in my office. I buy them for whatever and pretty much sell them at cost, because a lot of times what I'm trying to do for the patients is trying to get them to have their bottles last longer. So, if I get them for, I don't know, 10.50, I don't know what I get them for. 12.50, I sell them for 13 bucks. I make 50 cents. To me, it's kind of a way of giving back. They're going to come back every 3 months. It's a lot of my glaucoma patients. And I'm just trying to get them to not burn through their drops and try to help them on some of these medications. It's a really cool, I always tease them, nano dropper. It's really microliters. And here's a QR code. They might have a more updated one. I was chatting with Mackenzie out at the academy. But you could see they have tons of companies that they work with and try to be compatible with. All right. And that QR code's in your handout if you're going to go look for it. Cequa, again, this is by Sun, was approved in 2018. It's not that it's a new medication, but I wanted to talk about, again, when I opened up and talked about mechanism of delivery. It's still cyclosporin. It's not 0.1. It's a little bit less at 0.9, but they use this new nanomicellular type of mechanism that's out there. And nothing new. It's the indication, again, a calcineurin inhibitor, immunosuppressant, blah, 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 just like Restasis. Here's what they did. All right. Here's the lipophilic drug. Here's your cyclosporin. If you can get it to the lacrimal gland, to the conjunctiva, to the goblet cells, to where all it needs to work and do its anti-inflammatory work, it's great. But it's hard to get it there because of the eye being a robust immune system. Mucin is being produced. Mucin rinses things away. It's just the eye. How many times have you had a cold versus a conjunctivitis? People get upper respiratory, lower respiratory, but pink eye, when people get it, it's tough because you got something that overcame that ocular immune system. So you still have to work with that when it comes to pharmacology. So what they did is they wrapped it in this micellar. So this is a water-loving outside. So just think of it as when you drop it in, it penetrates the tears, and then it gets to the mucin, and it kind of releases this medication. That's what Cequa was doing with its micellar and the Sun. They just recently released this phase 4 study. Phase 4 means after, right? So phase 1, phase 2, phase 3. If it passes phase 3, then it usually makes it to the market. Phase 4 is after, and they're just basically trying to highlight when you compare it to Restasis or maybe generic cyclosporin at 0.5, again, half the amount almost at 0.9 versus 0.5. Vive has double the amount. And then you change the mechanism of delivery, you start to see now that you start getting a statistically significant for your cornea fluorescein stain, your symptoms on the Sandy score, your total conjunctiva, your Schirmer test, that's out there. So I'm not a big poo-pooer of, I'm not a big fan of cyclosporin. It's just that it's hard to get to the tissue, but these newer ones have kind of opened my eyes, and I have prescribed them with better success because not of the mechanism of action, but they've changed the mechanism of delivery that's out there. In the next 10 minutes here, let me run through some of this mechanism of delivery. We'll talk about IUs, and I do want to do a real quick public service announcement. So I'm going to go through this pretty quickly. We've been around with these lodopredanols. We have steroids, we have the ketones, and the esters. So your esters are your lodopredanols. They basically change the carbon 20 on it, and now it becomes an ester. Now plasma cholinesterase can break it down so that now you don't get the IOP or the cataract. So that's the difference. Ketones versus ester, plasma cholinesterase breaks it down. So lodopredonol has changed itself over the years. It's still the mechanism of action. It just went from a suspension where you had to reconstitute it to a gel where you didn't have to shake it to a gel that is micro size, that it allows it through all those ocular types of defenses that we talked about, the mucin. And then you had Inveltis suspension and Isuvis, which was for allergies. So really, the mechanism of action really hasn't changed much. When Ocular came out with it, it's now Alcon. They created a nanoparticular mucus penetrating, the MPP, to help get this molecule through the mucin, which is protection, and making it a smaller drug to get it there. So this nanoparticular mucus penetrating, they used in Isuvis this Amplify, which is now an Alcon product. So you might hear this from your Alcon reps rather than Color, because they have acquired this asset. And basically it helps with distribution and penetration. Lotamax SM, Joe and I speak on this medication. Basically, it's lotipretinol. I like it because when I speak with Tracy, my pharmacist, she says, yes, QID to TID, less medication, less side effects, and 0.5%, 1% down to 0.38%, less medication, less usage, you're going to have less side effects. So you increase in your safety profile that's out there. What did they do? They're using a low amount of BAK. They are using nanotechnology to get it through some of the defenses of the eye, the mucus and the tears and everything that we talked about a little bit earlier. I showed this slide earlier where it's very large, bulky, and small and nimble, and getting through the mucus helps it spread and get to the tissues that's out there. Tyrvaya, I'm going to skip through this. Just it's a nasal spray that's out there. You're hitting the parasympathetic system, and in a sense, you're hitting all the different tissues, or you're getting all the different as you spray the nose, hits the parasympathetic system. You're getting all the natural tears from the lacrimal gland to the goblet cells to the meibomian glands. We talked about the glaucoma. You have a glaucoma practice. We showed BAK is bad. IUSA is by Taya Pharmacy. I just spoke at the MSL. I had lunch, or I had breakfast. I had a coffee with him when I was out at the academy. Some really cool science coming out, some studies coming out, again, using it prostaglandin, IOPs maybe a point lower, maybe that's compliance, but you start getting more comfort. Maybe that patient will use the drop, won't forget about it, but it's a preservative-free. It's been in Europe since 2013. It's something that I am now playing around with, understanding as much ocular surface disease. I've now practiced 29 years. I have some patients that are now 15, 20 years on glaucoma meds. What did I do to that ocular surface? I do now see it. And so it does make me a little bit more aware of maybe I should be doing some preservative-free. And as Joe mentioned, that there are some, some generics hopefully that are coming out. So, IUSA allows me to have that. I have the samples in the practice. If you have a glaucoma practice, maybe reach out to Taya, find out who your rep is, get some in there and try it and see if it's going to move you. Now, let me throw this polling question open here real quick because I'm just curious. Have you had a patient come in using Ella here and you need to clear them for this medication? So Ella here is a biologic. It's used for ovarian cancer. And before the patient can use it, they have to be cleared by an optometrist. Have you experienced that out there? Anyone out there? Every time I just did a pharmacology talk, complications, and I folded this in there when I was at the academy. I had about 500 or 600 people in the room. I had about 8 people raise their hand. So when I do 100, it's usually about 2 to 3. So, all right, I'm seeing them roll in here. And you're going to see here. And if you want to put some comments in there, Joe will definitely do it as I go through here in this next 4 minutes. I want to talk about this medication. You can see we have a handful of colleagues that have used or have cleared patients. Let me go through this in a very quick fashion here. Ella here is a biologic drug, and it's an antibody drug conjugate. And it basically is a monoclonal antibody with a linker, which think of it as dynamite. Here is the ovarian cancer. This is a last-ditch effort for ovarian cancer patients. So what it is this is this FR alpha positive platinum resistant. Here is that receptor. This monoclonal antibody attaches it. It's all about the receptors. It's about the immune system. Here's the dynamite. So it attaches to the cancer cell. The cancer cell brings it in, and then the dynamite goes off, and you can see here it kills the cancer cell. Now, this is, again, for last-ditch effort for platinum-resistant ovarian cancer. We need to clear these patients. And there's truly a black box warning. When I work with Tracy, she says, literally, Greg, this black box pops up and we need to discuss with them. And then she signs off on these after she reviewed it with the patient, or whoever's prescribing this reviews it. So I'm going to go through a lot of these slides again quickly so I can get to the last page here that I want to show you, is that it does create like amiodarone, but much less than amiodarone. And amiodarone doesn't have a black box warning. This builds up into the epithelium. They think it's coming in from the limbal area. I just talked with Sarah out at the academy, and they have preventive measures. You got to do an exam. You get lubricants. You get steroids with these patients. So the cycle of following these patients up is every other, you see them for every 3 to 4 weeks here. I think I have it on this slide. Yeah, let me see. I'm getting lost here because I want to go quick. But right here, let me see. Right here, they're going to come in on steroids. They're going to start 6 times a day for the 3 days after the infusion, 1 to 4 days. They're going to come in on drops, and they're going to use lubricant drops. What you're looking for, the symptoms, a visual acuity, a slit lamp. Trust me, we all can do this. Here's what I was looking for. Monitor the patient every other cycle, which is every 6 weeks for the first 8 weeks and then 6 months. So basically, you're going to be seeing these patients for follow-ups, and all you're doing is reporting. You're not really adjusting the Elahere up and down. The oncologists, your gynecological oncologist are who you're going to be working with, and they build up these epithelial type of deposits. I haven't seen it. I've spoken to the optometrists that do this. They say, look, doc, it's treatable. You stop the medication, the patient survives, it goes away. So we could be a very big part. So 2 things that I point out when I do this talk is that reach out to your gynecological oncologist. And if you're up for doing this, let them know you'll clear the patient that's out there, and let your staff know that if they call, you're seeing them that day or the next day, not your 6 or 8 weeks. I'm booked up, because these are last ditch efforts for these patients. So I want to get to this here. I've kind of taken away all the different symbols that are on here. If you scan this QR code, it will bring up this ocular assessment. But what I want to point out, it's all within our wheelhouse. You do a visual acuity, that's the baseline. Then when you follow them up, you're looking for keratitis and keratopathy. You were all able to look for superficial keratitis. We're all able to evaluate if it's confluent. Is there stromal opacities? Is there a uveitis? Yes, no, yes, no. Send that off to the oncologist. On the baseline, they'll get cleared. On the follow-ups, they might adjust the Elahere up and down based upon what you're seeing that's out there. So my point would be, if you have any desire to do this, reach out to the gynecological oncologist in your area. Notify your staff, download this form, but then talking to the people that have done this. Remember, I haven't had my pace, I usually don't like to lecture on things I haven't done, but I felt that this was near and dear to my heart, that we wanted to help out and we could help these patients with ovarian cancer. But the people that I talked to have said after the talk is over that you have to be emotionally strong, because sometimes the patient will get worse and they'll pass away. So you have to be mentally tough. We're not used to that in optometry, where we see these patients and we're working with them. I've had patients pass away, but this is a last-ditch effort. They have hope, and you're working with them and you're clearing them, and they can pass. So that would be a little bit of a thought, that you have to be kind of strong to do that. So keep that in mind. So Joe, with that being said, I'm not going to do the last part, the neurotrophic keratitis. We'll do that at another talk sometime. Are there any questions that have come in?
No, but a nice comment from someone who thanks you for speaking on this, because she has been involved with patients like this. So we're good, Greg.
Okay, so I'm just gonna kind of skip through this. And I see the little red dot. So before I wrap it up, if this is just a screenshot from another one, I understand that I'm doing dry eye, blepharitis, keratitis, but you'll see the little red dot right here. And if you want to start that survey, click on it. And with that being said, it's right there. And I'll take any other further questions, Joe, or
We're
we
good.
can wrap up the CE. I'll let you make that call.
We're all out of questions, so we can wrap it up.
Okay. So thanks everyone for attending. I didn't get through the last part, neurotrophic keratitis, but maybe I'll do another pharmacological lecture here in the near future in 2025, since we have the 2024 season set up already. But I want to thank everyone for attending. Joe, I want to thank you for being a great moderator, helping me out, making some comments, and following that chat box.
All good. Thank you. And thank you for doing it, Greg. And we're very happy to help.